If everyone could please take their seats so we can complete this very busy 2 days. Thank you all. And thanks to the stalwarts who made it to the end. And I also want to add my thanks to all the facilitators and everyone who jumped in and helped to make this what has been a very, very exciting experience for all of us at the Carter Center. At this point, I'd like to ask Dave Shern to come up. And Dave is going to guide us through an exercise here at the end and try to make sense out of some of the recommendations and get them on the record. Thanks, Dave.
All right, great. Again, thank you all for being here. I know this is a very intense sprint for a day and a half, lots and lots of good information. And so what I'm going to try to do is just kind of walk through the major program elements and give you some of my observations and also some things that I noticed, some kind of common themes that I think emerged both across the work groups and also across the areas in which we were engaged and that we were discussing. So what I'll do is I'll go through, I'll start with enrollment and engagement, and then when I finish, rather than having a report out, if there's anything that you thought that your group highlighted that isn't appropriately summarized, and we'll sort of pause and we'll have a chance for people to make comments. I think the first thing that occurred to me in terms of enrollment and engagement was kind of a surprising lack of general knowledge about the infrastructure that is in place to enroll and engage individuals. So people weren't terribly, I've got to get back here, people weren't terribly knowledgeable about how the navigators are deployed around the country, who's sort of responsible, who's running this operation, who could be kind of hold accountable, which resonates to some of Secretary Sebelius's favorite questions, I think, probably right now. And so there was a real need, I think, for something that struck me kind of repeatedly throughout the last few days is we have an extremely complicated healthcare system. I mean, I can't recall who said it, but you were sat down and you were charged with trying to develop the most complicated healthcare system you could imagine. It might not be quite as complicated as what we have now. And the enrollment engagement process also requires that number one, people understand the general characteristics and features of the Affordable Care Act and what we're trying to accomplish. And secondly, that somehow be expressed clearly, understandably to individuals, and then a communication plan be developed to sort of roll that out. I mean, we were impressed in our group about how little we as professionals knew about the engagement and enrollment strategy, and we're impressed by the fact that what we heard from the general discussions about engagement and enrollment was a need to really expand out to various communities. That clearly wouldn't be enough to do it with the professional communities, but that many different communities need to be involved. A theme that really emerged, I think, over the 2 days and all of the sessions was trying to take this knowledge to where the people are, in a sense. And there was a lot of emphasis on trusted relationships. You know, we heard a fair amount about the degree to which individuals are kind of distrustful of the government. And there are some nefarious people among us, including my own personal congressman, who are spreading misinformation about how the navigators work, the kinds of information that they have available, which further complicates our task. So I think the goal, as expressed here in enrollment and engagement, was to try to keep it simple, keep it as straightforward as possible, clearly hone to the facts, go to where the people are, and play on trusted relationships. So if we could engage, for example, the faith community was one of the examples. People who are trusted, who have broad-scale access to individuals who often find themselves in the role of a helper. If we could use peers, thinking specifically about some of the challenges engaging persons who have behavioral health conditions, peers might be another trusted source. And then finally, another theme that emerged out of this was that we really need to think about about champions and new alliances. And again, drawing kind of on our group, but I think I still have some very similar observations out of the other groups. We should have strong shared interest with the insurance industry, for example, who are motivated to try to make sure that through the engagement process, they get a good mix in terms of young, healthy people, we always talk about that, to make the insurance part of the model work. Who are the other groups that we might have sort of a shared partnership with? There was a thought about the hospital associations, right? If this doesn't work, in some sense, the thing that Joe Parks emphasized about what's going to happen to disproportionate share and how we financed indigent care in this country for so many years, the hospital associations have a big dog in this fight. And without if this insurance reform doesn't work the way it's supposed to be, they stand to be at great financial risk as the disproportionate share goes away. So the notion here was keep it simple, have a communication strategy that disseminates what we know to various trusted groups that can help stimulate the engagement and enrollment process. And in doing that, think about people who we might not ordinarily think about as partners or allies for engagement and enrollment. So that being said, are there other things that people took out of that first session around engagement and enrollment that you'd like to highlight at this time? Oh, thank you. Yeah, since I'm sort of on stage, I think I should break into song. Do, 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 do.
I think media has been overlooked. Our broadcasters, they're first responders when we have terrible weather or other breaking news, and I think they're the voice of the community that's talking about it.
Yeah, right, and in some sense, another trusted resource, right? And if you think about a communication plan, clearly the media would be an important part of that and an important ally for us. Anything else about engagement and enrollment? I don't see a mix of noise. Yeah, I'm sorry, Tom.
Yeah, I think that people talked about, as you said earlier, lack of awareness about certain resources that are in fact available for providing information and messaging and that kind of thing. So I think increasing public awareness of how to access those resources and working on broader dissemination of this.
Absolutely, yeah, absolutely. And create a sense of sort of public urgency around the opportunities here. And I've seen some good, really some very moving media stories about people who are desperately in need of healthcare. And I thought Secretary Sebelius's answer when she was queried about why not put this off, about that people who have cancer and need healthcare can't put this off for 6 weeks. I'm not sure exactly that's where you're going, but I think it resonates to the same general set of themes. We then went to dinner last night. Do I have another comment? Oh, I'm sorry. Yeah, Leslie.
Harper talked a lot about the importance of involving peers as one of the trusted resources who could be providing information to people, particularly the folks that we're most concerned about.
Absolutely. Yeah, no, I think that they're a natural resource and they fit nicely into that category of individuals who are where the people are and who have a shared experience and a trusted relationship. So I think that's certainly an excellent point. Unfortunately, they threw the light on, which just blinds me. Yes, there you go.
Two things that I think that I wanted to add was around one, keeping track of some data about where people are being left out.
Excellent point. Yeah.
Was sort of based on our theories about where people are going to have trouble, but in relatively short order, we won't have to use theories. We'll know where people are being left out. And in that vein, I think that one of the challenges for all of us would be, as soon as we start hearing immediately where challenges are, we at SANTA and at HHS are really eager to hear where those problems are so that we can try and mobilize the federal efforts to alleviate those challenges as they arise. And there will be places where Like I heard yesterday about certified application counselors who, in seeing that the website wasn't working, said, well, I guess we don't need to do anything. And started turning people away, not even giving them the paper application, not doing anything. And so that's a perfect example of sort of a failure that we as a community should raise up as soon as we start hearing them. And then as data on actual coverage gaps, data on people presenting without coverage arrives, we can use that to direct our efforts going forward.
Kevin, I think that's a very important point. And it resonates to another kind of thing that I've heard again and again, and that's that this is going to take a while to develop. When you have a change of this magnitude, and remember the number of times that we've attempted healthcare reform, this is the closest we've gotten, perhaps ever, that you can't expect it to work smoothly instantly, and then we should adopt a sort of a continuous learning style for tracking how we're doing, where we're going, identifying those kinds of problems and responding to them, rather than being a fait accompli. So I think that's an excellent point as an approach. Now they can't see me on the camera, but I can see you. So that's probably a good thing. I had a couple observations from dinner last night that I thought were really important. You know, I always enjoyed listening to Howard and always learn something from him. And I think the point that Howard made, which I thought was really important, is that this shouldn't be an opportunity for us to repeat some of the problems that we experienced in deinstitutionalization. That insurance reform, which is what essentially the Affordable Care Act is not system reform in the broadest sense. And Howard was worried, and again, we've heard this, I think, in several of the other observations that were made throughout the course of the 2 days, that the kinds of services, particularly for people with more severe and disabling illnesses that we've worked so hard to develop and have done a better job of deploying, or perhaps the ones that are most in danger, and to the degree to which we focus on primary care as, and this is another theme that's emerged a lot, the primary care as a critical element in the identification and treatment of people with more severe illnesses, that we don't end up abandoning those people who need broad-based social housing and other kinds of supports in order to facilitate their recovery, or abandon recovery-oriented services, because I think it's clear from many of our comments that those are not automatically included in issues of insurance reform. So I thought that was a very important caution. It was interesting at the public health meetings. Steve Leff, who's known to many of you, talked about what we know about the treatment of persons with more severe illnesses in primary care settings, and was also warning us that this not be a deinstitutionalization redux, because insurance reform isn't everything that we need in order to realize the, Mrs. Carter's vision of a recovery, a possibility for everyone. The other thing that I took out of Ken Thorpe's comments, and Ken has, with his partnership to fight chronic disease, I think has done just extraordinary work to really focus attention on what are the major health cost drivers and outcome and factors that facilitate very poor outcomes, and that's chronic illnesses and multiple chronic illnesses. And I think Ken has, over the last few years, with some of us talking to him, has come to appreciate that the behavioral health illnesses are certainly chronic illnesses, and one could argue are the most chronic illnesses because they occur earlier in life than other conditions, because they're so poor typically in responding to them, and so disability develops. And one could argue that the general health conditions are the sequelae to unsuccessfully treated behavioral health conditions. And it's clear to me, and I think Ken has done a great job of making this point nationally and in the nation's capital, that we live squarely in the center of multiple chronic illnesses in terms of the conditions that we're concerned about, in that, in fact, the behavioral health management and prevention of those illnesses is an area where we perhaps have unique competencies. So I thought that was extremely valuable. And then Secretary Sebelius, what a great honor for all of us to be here with her to announce that those final rules have finally, after 5 years, been promulgated, and we can now move forward to actually try to aggressively implement them. I thought Tom did a great job emphasizing the fact that we've been working on this. I didn't realize that in the original 1980 Systems Act there was a parity provision. I remember the 1996 fight, and then of course the 2008 final passage with President Bush signing the bill within 20 minutes, because there was this thing called the Troubled Asset Recovery Program, the TARP, that got attached to the parity bill. And so the thing that we thought was going to kill us, because we thought there wasn't any way they're going to, parity, we were afraid, this is it, we lost it again because of this little Lehman Brothers thing that happened. As it turns out, that was the vehicle that allowed them to bring the thing that the Senate had back to the House and ultimately to the President. So it was a great opportunity to kind of revel in our success. And then the second part of that, of course, is the inclusion in the Affordable Care Act, which we've talked about a lot. My favorite story about that is the fact that when they were marking up the bill in Senator Baucus's committee, Tom has heard this so many times probably, that it was extremely partisan debate. And every Republican, remember that the Democrats controlled the committee, still do actually, that every time a Republican amendment was suggested, it was voted down, straight party line. Every time a Democratic amendment was suggested, it was adopted, straight party line vote, until Debbie Stabenow, the senator from Michigan, suggested that the Parity Act be adopted into the Affordable Care Act, and that passed unanimously. Nothing was passing unanimously. That just shows, I think, the progress that we have made, and of course Secretary Sebelius reminded us of all that this morning. So it was really a terrific chance to be here and to be part of that, and for us to, at least momentarily, celebrate some really, really important progress that we've made. Then came Joe Parks, in terms of access. And Joe's staff, I love his thing about the soaring. Is Joe still here, or did he take off? I love the bird, the flying and the beautiful visions and this and that, and having to land in a sea of reality. So Joe brought us right back to ground in introducing the access section. So now when we move past the dinner, past the Secretary Sebelius' comments this morning, and into our discussion of access. And one of the things that Joe appropriately emphasized is the fact that we've got work to do in terms of actually implementing all of this, and it's a challenge to all of us to feel good, but to certainly not get complacent. And I have never heard the Martin Luther King, you have to preach to the choir so they'll keep on singing. I thought that was just great. I'd never heard that before. And so we were preaching to the choir a little bit so that all of us will keep on singing and working on the implementation of this infrastructure which is in place, and it's really kind of where we're at now. Joe had some very kind of sobering numbers about workforce, and then again, this is a theme that's emerged again and again. One of the things, as I understand it, that really emerged in Massachusetts after Governor Romney's healthcare reform bill was adopted was a rapid exhaustion of the primary healthcare capacity in the state. And I think that we're anticipating similar workforce shortages. And then Joe gave us a lot of specific numbers about how that might play out, focusing most specifically on prescribers of medication, coming at kind of from a psychiatric perspective. But it seemed to me that there was a lot of discussion related to that, just about redesign of practice models. Leslie and others, greater use of peers and community health workers, and expansion to anytime, anywhere intervention using things like, many people now can contact their physicians via email, for example, and take care of things with their physician or their nurse practitioner, whomever, in a way that's more efficient than having to have a face-to-face visit. So I think that was an important element that came out in terms of having to continue to think about redesigning our practice models to accommodate some of the challenges that we're going to have in terms of workforce. In that regard, there was a lot of discussion really throughout both days around integrated settings, integrated services, again, the notion of working both, Joe pointed out that the CMHCs that were integrating primary care as opposed, or in contrast with the federal qualified health programs that had implemented behavioral health care. Joe's sense is that the CMHCs were doing better, making progress more quickly, probably in part because of these more recovery-oriented services, more peer-oriented services, and some of the other things that have developed around long-term care and support for people in the CMHCs that might be less true in the federally qualified health centers, the FQHCs. So I think that's encouraging. I thought for a while that we've had a lot to offer in terms of the work that we've done for years around long-term care for people with more severe and disabling illnesses to other chronic care conditions. And of course, this resonates back to what Ken was talking about in terms of the importance of chronic care for both costs and outcomes. And I think we've got a lot to offer there. This kind of definition of medical necessity, however, and the boundaries around what are medically necessary services versus other services that we might call recovery-oriented that might be seen as educational, for example, or vocational outside of medical is going to continue to be a challenge, I think, for us. And I know in our group we talked about, rather than perhaps changing the language a little bit from medical necessity to health necessity, getting kind of out of a more prescriptive, perhaps an acute care perspective into something that talks more about overall health and well-being. And I think that's something that plays into our notions of changing the practice model. Finally, there was a lot of discussion in the access area around notions of engagement in treatment. What can we do? I mean, we know that issues of meaningful engagement continue to be quite challenging. And I thought Peter's example of John wanting to be an astronaut was just an extraordinary example about what it really means to listen to someone and what their goals and aspirations are, and then working with them affirmatively from that framework to design a strategy that works for them, and in that case, understanding about algebra and trigonometry and some of the other things that are required for astronauts training, and then getting to the heart of the matter in terms of just an interest in air transport. I thought it was just a great example of a strength-based approach, one that involved, as I understand it, some of the important components of motivational interviewing in terms of really seeing things through your customer, your client, your patient's eyes. And that theme resonated with a lot of what we were talking about, even in terms of the overall engagement. This is in part the issue of trust and getting people involved. So, and then just in terms of other access issues, I'm talking about psychological access. Arthur talked about that earlier, I think, in sort of framing up the access section. And it's more than just having physical locations at which people can engage. It's having a process that's inviting to them, that's responsive to their goals and dreams, and that sees this as a problem-solving, collaborative venture as opposed to perhaps just a prescriptive, you do this and you'll get better kind of intervention. Other issues about technology, hopefully technology will help us all in this. We need all the good engineering we can possibly get to make this stuff work. So those are some of my observations about access. What have I missed? What are some other important points that people think we should talk about in terms of access? Everything you ever wanted to know about access. All right, so Joe brought us back to life with, no, I won't go through it again, Jim, but I know that it was so entertaining the first time that you really would like to hear it all again. Finally, service delivery. And in service delivery, it seemed to me that it was interesting to hear about, and was reminded, because I think, Tom, I was at that meeting around the primary care behavioral health intervention, unless it was another meeting, but I was at a meeting here that was very much like the one he was talking about. And it was interesting to talk about the fact that there was a pretty consistent, at least rhetorical understanding about what a high-performance healthcare system would look like. Recall that the kind of list of elements that people thought were necessary, that the physicians thought were necessary for a high-performance healthcare system. And then that was coupled, though, by sort of the reality of the complexity of what is happening in the healthcare system and how that reflects on the individual practitioners. I remember the slide that had the ACOs and the primary care medical homes and collaboration and integration and case payments, and all of this language about this complex healthcare system, and trying to have a rapprochement, if you will, between those things. Again, I think an important point being that there's a lot of enthusiasm about the possibility of doing this job a lot more effectively than we have in the past. There's a tremendous amount of vocabulary and complexity, and it's just not clear on the ground what that means for people. It's funny, Linda Rosenberg was talking about her son, who's, I guess, a physician, I think at Mount Sinai in New York, or he works there, I'm not sure he's a physician, and it's evidently an accountable care organization, and so she asked him, well, you know, how has your practice changed now that you're an accountable care organization? And Linda said he just looked at her quizzically and had absolutely no idea what she was talking about. The understanding, I just thought that the work that Tom McClellan did in his presentation around the understanding of chronic illness was just extraordinary in terms of reframing. So you can see the MATCH study, the NIAAA study, versus the ALLHAT study, with almost identical results and entirely different interpretations of what that meant in terms of the treatment of chronic illnesses. And I think in part what Tom was trying to do was just to say, as we think about service delivery and think about accountability models, it's very important that we have a broad-based understanding about the challenges involved in treating illnesses which can have a chronic course, that we never abandon the idea of people getting well, getting better, but we do that within the context of a lifespan developmental perspective, realizing that for many of these conditions, and all we have to do is think of our own personal struggles to change any important behavior we want to change, that those things are long-term, and that we shouldn't sort of consider behavioral health a kind of a poor stepchild to other chronic illnesses, which I thought was really important. And of course, that has really important implications for the design of the service delivery system in terms of the kinds of ongoing supports. Right? Part of this thing was that this is a 3 to 5 year process. It's not a 30 to 90 day process, and it's not one that probably is successfully terminated by referral to a church basement for an Alcoholics Anonymous meeting. And it's really important for us as we think about service delivery to think about those issues as well. We heard again about the importance of measurement and quality standards and how those can be incorporated. And I think in our group, and I saw this in a couple of the other groups as well, this notion of population health and what population health means. I thought we had an excellent epidemiology 101 lecture on population health and intervention strategies and their effect on population health. And something that came up in our group is a tendency for us as a community not to talk about prevention almost exclusively in terms of screening and early identification as opposed to real primary prevention, universal prevention interventions. And as you all know, we have a very strong science base with regard to the effectiveness of primary prevention. We have lots of techniques that can reduce environmental risks or can promote the development of individual resilience. And as we think about our service models, we just have a natural tendency, I think, particularly in our community, to gravitate towards treatment and then to think that early identification, which is very important, so it's not to minimize that at all, but to think that somehow if we're doing screening and early identification, we're doing all we need to do in prevention, And I think that this population health approach and the science base that we have available to us now really suggests that we need to systematically, in terms of thinking about our service delivery models, think about primary prevention interventions and how we can start to actually develop the public health infrastructure necessary to realize really the strength of our science, and ultimately to start to drive down some of the rates of chronic behavioral health conditions and other health conditions that are really threatening our overall human capital. So we really want an inclusive service delivery system that broadly incorporates our science base, and we need to caution ourselves not to automatically veer towards treatment, earlier identification and treatment, as the only tools in our tool chest are the ones that we emphasize. And that's going to be tough because we don't have the financing mechanisms in place for these primary prevention interventions. Typically, there are actually all kinds of them, but they're broadly scattered throughout the government. But my sense is, and at least some of the participants' sense was that that's where the highest leverage ultimately will be, and it's going to be a challenge for us to get our service delivery models lined up with what we know to be the case. So it was a terrific 2 days. Some really common themes is, number one, this is complicated stuff. It's not been well explained. It's hard to explain. We need to do a better job educating ourselves and others with regard to this engagement enrollment process. Everyone should apply. No one should be discouraged with regard to that. We need to think about going to people where they are in terms of both engagement, adjustment, adjustment's good as well, and treatment. That part of that will involve redesign probably of some of our delivery models, that we're going to be forced to do that. Just in light of our workplace shortages, we're going to need to press other kinds of people into service, and we have some good models in terms of peer involvement, community health workers, behaviorists who work in primary care practices. And if we're going to get the job done, we're going to have to do that. That we need to think about strength-based approaches. I'm sorry, John, the one thing I left out, I'm just reminding myself, is the importance of thinking of health promotion when we think of and promotion is not a concept, I don't think that's well understood. From my own experience, trying to get my head around promotion and how it relates to prevention, it's not an easy thing to do. But your point, which I thought you made so eloquently in our group, is that promoting health and well-being is in some sense an easier sell than preventing disease. And everybody has a stake in being healthier, more active, more productive, et cetera, et cetera. And that plays very much to the strength-based theme that we discussed in terms of engagement and designing programs that really work for individuals, empowering them to become perhaps much more active in terms of their treatment processes than they've done traditionally. So let's keep it simple, have communication plans, emphasize strengths, look at our practice models, to see how we can accommodate kind of this oncoming demographic trend of the baby boomers that Tom and I are both proudly members of, and there are, I think, a couple others in the room who might be in the baby boom generation. And it's a very exciting time to be here. So are there any other comments about service delivery or anything else from the 2 days? Yay for me. Thank you, Jen.
That's a hard job, summarizing a packed day and a half. Thank you very much, Dave. Really appreciate you doing that. At this point, I just want to remind you all that the shuttle will be leaving at 4:15 for the airport. I know many of you are going to need to catch that, so please keep that in mind. We're going to probably end a little bit early today, so you'll have a little more networking time, but don't let it get away from you. Make sure you catch a bus. At this point, I'd like to invite Mrs. Carter to come up. And share some final thoughts with us.
Well, David, that was a really good wrap-up. And I don't think there's anything else I can say now with that to what has happened these last couple of days. It was a great symposium. Every year I think it's the best one we have, it's the best one, but I don't think anything's going to top this one, not with Kathleen coming. I think we did learn that there's so many challenges ahead. We're going to have to be diligent in checking on what's happening in our own states, because we want the parity bill to be implemented as it was meant to be in the Wellstone Diminished Bill. And so I think we remember that. Well, to have all, and the topic, I mean, it just couldn't have happened at a better time to focus on the Affordable Care Act. And not only was it good, and it was good for us to know, but it came with all of this confusion. And so it was so good to have presenters talk about what's really in it and what it means. And so much to learn, and so complicated, but anyway, well, all of that, and then to have Kathleen here. When I found out she was coming yesterday, I found myself shaking. It didn't last long, but it was with excitement, I'm sure. 33 years. We recommended it in the Mental Health Systems Act of 19, where we included it. And that was 1980. 33 years I've been working for parity. I've got a lot of notes written down, but one thing I want you to know is there's going to be an online survey we're going to send to you. I hope you will all fill that out and send it back to us. That helps us a lot as we plan our symposiums and see what's good and what might not have been so good, or how we could do anything better. So that would be very helpful to you. Well, I think now I'm just going to end with thanking everybody. Thanking you all for being here. It's just been wonderful. It's always good. Symposiums are always good because we're with people. Everybody that's working for the same thing. And it's so exciting to me. And I want to thank the funders. I named them all last night. We could not do what we do without our funders. They're really special. The presenters, the facilitators, the planning committee, and you have the planning committee is listed on the back of your grade program. And I think the planning committee and the Carter Center staff need a big round of applause. It was so great. Thank you all. Have a safe trip home, and we'll see you again soon. And we'll be looking to hear from you, and being sure that you're where you are in your position, checking to be able to sure everything's going to be the way we want it. Thank you.